looking at the date today, May 30th, 2020. So if anybody's looking at this having been recorded, and for those of you in the audience, I first want to acknowledge what's happening in Minnesota and what's happening in the communities right outside your doors. And I will say that we are with you across the country. I'm here in Connecticut, and we are with you. And thank you for participating today, despite what's happening right outside your own homes. Thank you for inviting me to teach you a little bit about sickle cell disease in the midst of the COVID-19 pandemic. So first of all, I think probably at this point, most of you know a bit about COVID-19. It's a brand new virus that was first identified in China at the end of 2019. And since then, we have seen global spread. And in many parts of the world, we believe that the pandemic has not quite peaked, that there are more new cases day after day. There are a lot of implications for being a new virus, and primarily that means that none of us on Earth have been exposed to this virus before, and therefore our immune systems are not able to as easily fight it off. When you get exposed over and over again to a virus, your body builds up immunity, but when you see it for the very first time, your immune system has to start from the beginning. And so depending on how strong your immune system is, and whether or not you have other medical problems that can make it more challenging for you to fight an infection, that's primarily why you're seeing such differences in how this disease is affecting different populations of people. It's important to know that the knowledge that we have about COVID-19 and how it affects individuals with sickle cell disease is evolving. And it's critical that you definitely stay regularly informed, because what I tell you today could be a little bit different tomorrow. And I think all of us, having been living in this pandemic for weeks and months, I think you can understand that. So it's important to go to your local resources, to talk to your local sickle cell chapter and get the most up-to-date information. So when the pandemic was starting to really break in the United States around March, I looked at the map of where COVID-19 infections were first breaking out across the United States, and that's the map on the right side. So all of those red dots are where there were hotspots of the COVID-19 pandemic brewing. And it really hit me hard when I remembered that there was a really nice map of where individuals with sickle cell disease live in the United States. And that's on the left-hand side. So each of the 50 states is represented there. And the darker the state, the more individuals with sickle cell disease are believed to live there. And what was really striking to me, and I think to a lot of experts in sickle cell disease, was that these two maps are almost superimposable. And so as this pandemic was taking off, it was taking off in the communities in which a lot of individuals with sickle cell disease live. And so we knew that we needed to mobilize our efforts to figure out how best to advise our patients and their families, and also how best to advise healthcare providers to manage sickle cell disease in the setting of this emerging pandemic. I also want to highlight something that a lot of people are not necessarily familiar with, and that's the fact that although sickle cell disease is considered a disease primarily of Black and brown individuals, and it is primarily when you look across the world, more than 50% of individuals diagnosed with sickle cell disease annually come from 3 countries: the Democratic Republic of the Congo, Nigeria, and India. However, recent migrations, primarily economically driven migrations out of Africa and the Middle East to Europe, have increased the numbers of individuals living with sickle cell disease in European countries. And one of those countries that has had increasing numbers of these migrants in the last 1 to 2 decades is Italy. And if you recall, after China, Italy became the hardest hit country with COVID-19. Italy was battling COVID-19 well before the United States. And Italy was beginning to think about some of the issues we were thinking about in terms of how to manage individuals with sickle cell disease. So we have, I'll tell you in terms of what we've done to try to come up with recommendations about how to care for individuals with sickle cell disease was in large part able to be done because we looked to our Italian colleagues to help us because they were on the ground fighting this virus well before we were. So what do you need to know about COVID-19? Well, first of all of us are at risk of getting infected. But it's important to remember that individuals who have sickle cell disease have generally weaker immune systems than most other people. And the best way to prevent any serious illness associated with COVID-19 is to keep from getting the infection in the first place. That is still the recommendation because we don't know in any given person how seriously the illness will manifest itself. And I think we have to recognize that there are some unique challenges in the United States in terms of fighting COVID-19. First of all, we have a very disjointed healthcare system when you compare to other countries around the world where there are single payer systems, and it's just easier not only to deliver and receive healthcare, but it's also easier to track diseases and diagnoses because there's one medical record system for an entire country. We also have to acknowledge that we experience a pattern of systemic racism in the United States. And I made this slide before this week, before what began to erupt in Minnesota. This is the cover of the New York Times from about 2 or 3 weeks ago, actually. It's an opinion piece, and I think it points very well to the fact that as we've begun to understand more about the COVID-19 pandemic, we've begun to understand that communities of color and communities where there's economic disparity appear to have worse outcomes related to infection with this virus. And I think we are still trying to understand why this is, but I'm fairly confident that this will have less to do with the virus and more to do with some of the historical systemic socioeconomic practices that have made it very difficult for individuals of color in this country to gain access to healthcare, to gain access to employment that allows them to have the more quote unquote optimal insurance that gains them the ability to see some of the best physicians around. We have to also understand that in the United States, adults with sickle cell disease have historically had very poor access to care. You know, children born with sickle cell disease are diagnosed in all of the 50 states now. It's been that way for over 15 years. And once they're diagnosed as newborns, they immediately are put into pediatric care at one of the pediatric sickle cell programs. But historically, what happens is when they turn 18 or 21, and they can no longer be seen in a pediatric practice, they find themselves in no man's land, essentially trying to get care through emergency departments. And so you can imagine that all of these elements that I describe here that are fairly unique to our country really make it even more challenging to manage a pandemic. So, I like to call what we're living in the sickle cell community at this time sort of a new type of sickle cell crisis. And the reason I use that word crisis is although we have tried to get away from that term, historically, a crisis has been what people characterize the hallmark of sickle cell disease, which is the acute episode of pain. and it's very commonly called a pain crisis. So individuals with sickle cell disease have these episodes of severe bodily pain that come out of nowhere and requires them to seek medical attention. And if they have a healthcare team or a physician, then they're able to call that person and get recommendations on what to do. And sometimes they're able to manage well at home if they have the appropriate medication at home to help them manage their pain. But if they don't have a healthcare provider that they can count on and call for help, or they're not able to easily access pain medication, most of these are opioid-based pain medications, and there's difficulty with accessing what people consider to be addictive and restrictive medications. And individuals with sickle cell disease have suffered an inability to gain proper access to these medications. Then they have no other option than to go to a local emergency department. So generally speaking, we want to continue the message that individuals with sickle cell disease should have close contact with the medical system, preferably with a medical home. But if not, then they have no other choice than to go to an emergency department or a hospital when issues arise. However, this conflicts entirely with the widespread COVID-19 mitigation measures that have been in place across our country, recommending that people stay at home as much as possible to minimize getting infected with the virus. So you can imagine that for patients and families, this has posed a real logistical challenge. How do I continue to get the care that you're telling me I need and you're telling me is important for my health and my longevity, but you're also telling me to stay at home? How do those two messages work together? And then from the healthcare perspective, the healthcare provider and healthcare system perspective, this disease has posed some diagnostic as well as treatment challenges as we try to provide healthcare to individuals with sickle cell disease during the pandemic. And I'm going to explain to you what I mean by that. So some of you may be familiar with a term we use called the acute chest syndrome. So the acute chest syndrome is something only seen in individuals with sickle cell disease. What it is a constellation of signs and symptoms that can include the patient telling you they have chest pain, they have a new cough, they have fever, and then if you bring them in and you examine them, you may find that their oxygen levels are low, something we call hypoxia. And if you check a chest X-ray, you may see that there's an abnormality, something that we call new lung infiltrates that look like pneumonia. And so if you look at the X-rays on this slide, the X-ray on the left is of a person with the acute chest syndrome, somebody with sickle cell disease with acute chest syndrome. And you see all those fluffy white areas, they're not supposed to be there. In between the ribs, you're just supposed to see darkness. But you'll see on the right, that is a chest X-ray of somebody without sickle cell disease who has COVID-19. And I think most people can see that these look pretty similar. And you'll also note that the signs and symptoms of acute chest syndrome, like cough, fever, low oxygen, chest pain, these are all symptoms that people with COVID-19 can manifest as well. So COVID-19 and the acute chest syndrome look very similar. And so our concern as this pandemic was erupting was that individuals with sickle cell disease could get COVID-19, present to an emergency department, and have an exacerbation or development of the acute chest syndrome because of the COVID-19. Okay, that COVID-19 would be a trigger for the acute chest syndrome because we know infection can trigger acute chest syndrome in individuals with sickle cell disease. We were concerned that the acute chest syndrome may be overlooked as a superimposed diagnosis if the patient tested positive for COVID, that they may just be simply treated for COVID-19 and acute chest syndrome not be considered. And the problem with that is that the treatment of acute chest syndrome is different from the treatment of COVID-19. As many of you probably know, COVID-19 doesn't have a specific treatment, although many have been tested, evaluated. Whereas the acute chest syndrome, in addition to needing to give the patient intravenous antibiotics and oxygen support, requires, in most circumstances, a blood transfusion. And no one is giving blood transfusions to anybody with COVID-19 infection. It's not indicated for treatment. So we were very concerned that the acute chest syndrome would be a missed diagnosis in our sickle cell patients. And moreover, even if it was diagnosed properly, we were concerned that there would be increased mortality and respiratory distress in individuals with sickle cell disease because both of these diseases affect the lungs so severely. So that's just a bit of background in terms of what we were the most concerned about when this pandemic was erupting. There are a lot of people who ask me, well, has anybody with sickle cell disease been diagnosed with COVID-19? And if so, how have they done? And so I will point you to this registry, and the website right there is accessible to anyone. And this registry was developed out of the Medical College of Wisconsin, and it is a voluntary registry where any healthcare provider or any patient, for that matter, who's been tested positive for COVID-19, or a doctor who's diagnosed a sickle cell patient with COVID-19 can input information about that patient into this registry. And there are no identifiers. You can't tell who the patient is, but it basically gives demographic information like age, gender, race, and basically how they did with the infection. I just want to make sure you're clear as I show you these data that since this is a voluntary registry, we're not exactly sure what the universe of COVID-19 infections is. So not every case of a patient with sickle cell disease with COVID-19 is in this registry. We know that, but at least this gives us a snapshot. So this is a little bit of the information that you will see on the website. I last looked at this about a week ago, and it's updated about once a week. And you'll see that 188 cases of individuals with sickle cell disease who are diagnosed with COVID-19 are reported in this registry. Most of these are from the United States, but there are some data entries from around the globe. You'll see that the average age was about 29 years, and of a female gender. You can see the age distribution at the top right. So infections occurred at every age, but there may be a little bit of a peak in the young adult, sort of the early 20 age. Could possibly because these individuals are in and out of their homes a lot. They may be college, they may be working. They most likely have jobs that have not allowed them as easily to work from home. So we see that there seems to be a little bit more of an infection rate in the young adult community. And as expected, the majority of individuals are of Black or African American descent. This is a slide that shows you of these patients with COVID-19, what did they look like when they came in for medical attention? And you'll see in green there that the two most common signs or symptoms that they presented with before they got diagnosed with COVID-19 was pain, so a pain episode, and pneumonia. So those seem to be very common features that lead to a diagnosis of COVID-19. Now, of those 188 patients in the registry, there have been 14 reported deaths, which at the last time that this registry was updated was about a 7.5% mortality rate. 7.5% is far higher than any of us want. At the same time, we did expect to see potentially higher rates of mortality. So in many ways, this is reassuring. In many ways also, I want to caution that I truly believe, although I can't prove it at this time, that part of this may be related to our community taking the stay-at-home measures very seriously. And that very likely the actual number of infections in the sickle cell community is probably very low because people have done what they've been asked to do and have limited the chances of getting infected in the first place. So I think this will come out in recommendations I show you in just a few slides ahead. So although clearly this 7% of individuals would not have died COVID-19 pandemic, and that is disturbing. At the same time, I just want to make sure that everyone knows, at least as of the recording of this presentation, that this has been reassuring to date. So I hope I've impressed upon you that sickle cell disease has the potential at least to be a very high risk underlying condition for severe COVID-19 infection. And I just want to let you know that at the Sickle Cell Disease Association of America, we recognized pretty early that we needed to help our patients, their caregivers, and healthcare providers with some guidance on how to be prepared for this pandemic, how to stay prepared, what safety and prevention measures to take, how one could modify their usual healthcare utilization patterns, meaning can you get healthcare without leaving your home? That was a new question for all of us, but we knew that it was important to at least try. And then what are some basic treatment recommendations? But we also recognized that this wasn't all about health. This was also about other aspects of living during a pandemic, which includes another component of health, mental health, which I know will be a focus of a later presentation today. And that patients and families also needed financial support, that many of our patients and families were being severely impacted in an economic way, and that there was definite financial instability associated with living in this pandemic and an inability to maintain a consistent employment in many ways. A lot of our patients and families are at-will employees or considered quote unquote non-essential employees, and many found themselves with an inability to get an income during this pandemic. We also recognize that there could be blood shortages. And the reason this was important to the sickle cell community is because for many individuals with sickle cell disease, regular blood transfusion is the mainstay of their keeping healthy. One of the most common reasons that individuals with cell disease get blood transfusion is to prevent strokes if they are deemed to be at high risk for a stroke, or if they've ever had a stroke, they get regular blood transfusions nearly every month to try to prevent the next stroke. And we also know, as I told you, that blood is important to treating the acute chest syndrome. So we were very concerned about potential blood shortages during this pandemic, and we continue to be, because as you probably know, blood donations are voluntary. All the blood that's collected in our country to be donated to people who need it is collected on a voluntary basis. And a lot of volunteers during this pandemic have understandably not been as willing to leave their homes to go donate blood. So we knew we needed to address this as well. So what were SCDAA's general actions? Well, first, to educate and make people aware, to help fundraise for our local communities, and to participate in blood donation calls to action. So I wanted to let you know that the education and awareness has really been an effort of one of the committees of the SCDAA called the Medical and Research Advisory Committee. We call it MARAC. MARAC is a standing committee at the SCDAA, currently is composed of 33 members, experts across the world. Although most individuals are from the US, we also have experts from Italy, the United Kingdom, Canada, Ghana, Tanzania, and Lebanon. And that the input of all of these individuals has been essential toward our ability to develop education and awareness materials for the community. We also not only have hematology experts and nursing leadership experts, but we have 3 prominent psychologists who have a lot of experience in sickle cell disease who have helped to develop these recommendations as well. So what did we do? We got together in the middle of March for the first time as things started to look like they were going to take a turn for the worse in the US. And in our very first call on the pandemic, we decided 3 things, which I think were important. First of all, patients and their caregivers needed education and guidance, and we needed to get that to them quickly. So we needed to develop a patient and caregiver advisory that gave advice and answered some frequently asked questions. And we needed to get this information out, and we needed to make it easily accessible. But we also realized that we could not give messages to patients and their families, particularly when it came to changing patterns of healthcare utilization and reducing face-to-face visits with medical providers, if we didn't give that same message to the healthcare provider community. Okay, so I think for the first time that I've seen, had made a sort of concerted effort to make sure everybody was on the same page. So this is the first page of a multi-page patient and caregiver advisory, and I'll go through a little bit of the recommendations in subsequent slides. But you'll see that this is the very first iteration. It was published on March 28th and put on our SCDAA website. It's been updated several times. Our goal with both of these advisories is to update them as more information is available and on average of every week. Because as you know, this pandemic has evolved and the recommendations have changed. This is the healthcare provider companion advisory. It looks very similar. It was also published for the first time at the end of March. And I'm not going to go through this one in detail in subsequent slides, but just to give you some highlights, we gave strategies on how to incorporate telemedicine to keep patients home and well, but also continually receiving their healthcare through telemedicine, whether it's a telephone call to your provider or a video conference. We also recommended that physicians and nurse practitioners, all the healthcare team personnel, preferentially prescribe to pharmacies that could deliver to patients so they didn't leave their homes to pick up a prescription. We recommended strongly that providers allow for patients to receive home opioid prescriptions with electronic prescriptions. Most of the time, new opioid or refilling opioid prescriptions has required a face-to-face visit, but we had stressed that we needed to try to keep patients at home even during their acute pain episodes if they could manage at home, and we needed to make it easy, but we needed to make it safe. So we also recommended that an antidote be on hand at home, something called naloxone. And we also recommended that everybody stay on their chronic disease management medications, that transfusions should be continued if it were deemed safe to bring patients into the clinic for transfusions, that if people were on clinical trials, that they should probably stay on them, but to, at this point, halt new clinical trial enrollment with exception unless it was critical to the patient. So I told you we are a global committee. So because of that, we had the ability and the insights to develop translations as well as adaptations to the advisories. So we now have translations not only in Spanish, but Italian and Arabic. And as on the bottom right there, you'll see we have also an English version, but an English version that's more appropriate to sub-Saharan Africa, where the language that's used, the descriptions of how you get your healthcare, which can be a little bit different, are just tailor-made to those living in sub-Saharan Africa. We've developed a series of webinars where we have gotten our message out. This has not only been across the US, but even on the continent of Africa. We've also looked to our psychology experts to develop programming and education around mental health and COVID-19 for individuals with sickle cell disease. All of this information is on the Sickle Cell Disease Association of America website, every single bit of material that you see here. We also realized that children are different from adults, and children do have sickle cell disease, and that we needed to have an opportunity to have a directed educational webinar focused on children with sickle cell disease and focused on their parents and caregivers. So we called this particular educational webinar a big challenge for little people, COVID-19 and children with sickle cell disease. And this is also available on our website. We also realized that we needed to develop a little bit of a few positions during this pandemic. And one of them was as our leaders, our government leaders, economic leaders in the US were discussing reopening our economy back in April, we decided that it was important that we send a message at that time to our sickle cell community that we didn't agree that relaxation of the mitigation measures should take place that quickly. We're very concerned that if individuals with sickle cell disease in the middle of April or end of April just started going back to work and going to the grocery store and going to cookouts and barbecues as the weather got better, was just not a good idea. We wanted to keep the infection rate low. So we took this position to continue as much as possible to practice physical distancing, wearing masks, and only leaving your home for essential trips. And that if you did work outside of the home, to ask your employer to allow you to still work from home, or if that was not possible, to institute measures in the workplace that created physical distancing as much as possible. We also wanted to make this easy for patients as well as parents of children with sickle cell disease. And so we created 2 templated letters that are on our website that patients could access, download, print, and hand to their physician and say, can you fill this out for my employer so that my employer can give me the accommodations that I need? The left-hand side, as you see in the red bracket, is a templated letter for a person living with sickle cell disease that needs to give a letter to their employer. The template on the right, as you can see, is for a family member of somebody with sickle cell disease who's in the home, because I can't tell you how many times we've been asked, oh my gosh, like I work in healthcare and my child or my cousin that I live with has sickle cell disease. I'm afraid to be in the home with them. And those folks need accommodations as well. We also developed a campaign, fundraising campaign, to raise money for our communities. And within just a few days of launching this in March, we hit our target of over $100,000. And that money has gone back into the hands of those who need it in our communities. You can imagine that something as, I don't want to say simple, but something as important as just having Wi-Fi or a laptop computer at home for your child with sickle cell disease so they could take part in remote learning has been a challenge for many of our families. And even our families who have one desktop computer or one laptop in the household, that hasn't been enough if you have several children at home who need to do remote learning at the same time. So these grants have been essential. Call to action. We organize efforts together with our member organizations and the American Society of Hematology to develop strategies to encourage safe blood donation in our community so we can keep the donor blood supply where it needs to be. Just a little bit on what we are telling patients and caregivers about being safe during the pandemic, what you and your family need to know. First of all, it remains that the only way to know for sure that you have COVID-19 is to get tested. There's no other way to know. The most common symptoms include to be fever, cough, and shortness of breath. But it's important to know that what we're understanding now is some people also present with diarrhea, a change in taste or smell, and sometimes in children there can be rashes that they present with first as a manifestation of the disease. And if you have any of these symptoms, you need to call your doctor right away to figure out what to do next. But call 911 if you have any severe symptoms, lots of difficulty breathing, unusual or different pain or pressure in your chest. If anybody tells you you seem confused or if you can't wake somebody up, you need to call 911. And one of the common ways to know that somebody's not getting enough oxygen is darkening of the lips or face. And if you see that, you need to get seen emergently. How can you prevent the spread of COVID-19? First of all, we still feel strongly that stay home unless it's absolutely necessary, and to keep physical distancing in place. We realize that some communities around the country at this point are opening up for business. But I think the important message here is that if you can still try to practice physical distancing, wearing of a mask when you leave your home, and only going to places you really need to go, to continue to do that for a while until we see if there are going to be additional increases or waves of this pandemic. Continue to wash your hands, avoid touching any part of your face because that's how we know the virus gains entry into our body, and disinfect frequently touched objects and surfaces, including your workspaces. How do you get and maintain yourself and your family in a prepared way? Always have your medications refilled, always. Contact your doctor before your medications run out. Our sickle cell programs and most general medical centers are allowing for remote telemedicine telephone visits. You can call and ask for a visit for your routine care over the telephone or by video conference and ask for your medications to be refilled. Make sure you have a thermometer at home that works, because if you call your physician and you say you think you might have COVID-19, one of the most important things they're going to want to know is if you truly have a fever. Not if you think you have a fever, but if you actually do. And so take your temperature and document what it is, and clean it in between uses, particularly if it's not just your thermometer. Clean it in between with anything you can, any household cleaner. And continue any prescribed medications that you're on. Now more than ever is the time to take your hydroxyurea if you're on it. Now more than ever is your time to take anything that you have been given by your doctor to make your body stronger and healthier. Even though these things don't necessarily make you feel better on a day-to-day basis, they may, and they may be preserving your organs and make it all that much easier for your body to fight COVID-19 if you get it. Make sure you have household items and groceries available. Stay in touch with other people in the community from a distance, phone, text, email, and keep your children occupied as much as possible if you have children at home. This is going to be particularly challenging as kids get out of school, but finding ways to keep them occupied and thinking ahead about, well, if you get sick and you need to go into the hospital, who's going to watch your kids or your other loved ones? Or if you have pets, what are you going to do with them? And then see again if working from home is an option. I'm cognizant of the time, so I'll go through this a little bit more quickly. If you have a fever, again, call your doctor or healthcare team first if you're not severely ill. If you are, go call 911. But remember, don't get nervous just because you have a fever. Lots of things cause fever. Most of the time, it's not going to be COVID-19, okay? So if you have a fever, call, and your healthcare team will let you know what to do. What about if you're getting chronic transfusion? Should you continue? Yes. At this point, there is no evidence that COVID-19 is transmissible by a blood transfusion. So there's no reason to believe that the blood that is given to you has COVID-19 in it. And so if you have concerns about leaving your home or going into the clinic to get your blood transfusion, call your doctor's office first, see if they've got measures in place to try to minimize your chances of getting COVID-19 from somebody who might be in the clinic or walking around the hospital hallways. Bottom line though is talk to your doctor. If you get sick, should you go to the emergency room? If you're very sick and you don't have a doctor that you can call on for help, then of course this is your best option. But if you have other options or you're not quite that sick, you feel okay, call your doctor first for advice. ERs around the country are still filled with people with potential COVID-19 infection. And the last thing you want to do is go to the emergency room for, and not have COVID-19, but you pick it up while you're there. So if you can call your doctor first before going to the ER, please do that. What if you work in healthcare? A lot of our families and even some of our adult patients with sickle cell disease work in healthcare. And so they're considered essential employees. They have been through the entire pandemic. They haven't been able to necessarily not go to work. But they've been concerned not only about getting the virus at work, but bringing the virus home to their families. So some practical advice is to keep a change of clean clothes in a bag, and either before you leave work or just before you go into your home, if you've got a private place to do this, to change into your clean clothes and put your dirty work clothes into the bag. Leave your shoes at the door. Don't wear them into the home because you may carry the virus potentially into the home on the surface of your shoes. Separate your dirty work laundry from your other dirty laundry and that of the other people in your home, and shower as soon as you get in the home if you can, and certainly before you touch surfaces or give a family member a hug. What if you don't have sickle cell disease, but you still want to help? Donate blood, donate blood, donate blood. Get someone you know to donate blood. Call everybody you know. Anybody that's young and healthy and willing to do it, have them donate blood. And people with sickle cell trait can donate blood too. There's a little bit of a myth out there that you can't, that you're not eligible. You are. You're eligible if you have sickle cell trait. How to talk to children. Be calm and reassuring. Try not to have them watch the television too much. It's scary to see what's on TV about COVID-19. But make sure you talk to them when you're calm. If you're overwhelmed by the pandemic, that's not the moment. And teach them how to be empowered by allowing them to learn how to reduce the spread of germs. Teach them how to wash their hands. Teach them not to touch their faces. Teach them when to wear their masks. And how do you stay informed? Well, first of all, keep connected to the Sickle Cell Foundation of Minnesota. That is important. That is your immediate lifeline to good, trusted information. There are other websites I've listed here, including the National SCDAA, SickleCellDisease.org, an online curated information platform that the SCDAA has called One SCD Voice. You can go to the CDC's COVID-19 webpage. You can go to that registry on sickle cell disease and COVID-19 that I showed. It's called covidsicklecell.org. Or you can go to the American Society of Hematology at hematology.org. Thank you very much.
Dr. Andemariam, thank you so much for giving an excellent presentation and answering so many of our questions. We're going to move on to our next speaker, and then at the end, we will have all of our Q&A. So we hope that you will continue to join us if you are able. Our next presenter is Dr. Alex Boucher. Dr. Alex Boucher is a local expert here in Minnesota at the University of Minnesota, and we are very excited to have him, and we know that his presence in Minnesota is in fact making things that much better for our patient and provider community and bridging the gaps, much of what we at Sickle Cell Foundation of Minnesota are working very hard to do. So I will turn things over to Dr. Boucher and so that he can talk about transition, paving the road to better care. Dr. Boucher, go right ahead.
So you guys can see my screen now? They're good? Okay, great. So I get the privilege of talking about transitions, although I definitely have to acknowledge Dr. Andemariam as a leader in this realm of our care, having referenced a lot of her work, both for this presentation and just in general. For a bit of background for those of you who I don't know, I am a MedPeds trained provider and did my training up here in Minneapolis. I did pediatric hematology oncology at Cincinnati Children's, and so I'm back. And I do actually bridge the gap where I do pediatric hematology at the University of Minnesota, and then I have a scope of care in the adult, an appointment in the adult division of hemonc, and with a focus particularly on those under 30 with hemoglobinopathies like sickle cell. So that is a big focus of my care, and I'll talk about some of the work we're doing throughout this process. don't have any conflicts of interest. We'll talk about transition burden, sickle cell in particular, but just about adolescent and young adult transitions, or AYA transitions as they are in the nation. I will touch a bit on COVID-19 complications, although Dr. Andemariam spent much more time on that, appropriately so. And then we'll talk about the communal approach that we're taking in the university, or in the state, to really kind of improve the care across the board. So when we talk about transitions, really they are leaps of faith, and that is to say, care structures across the board are generally different for pediatrics and adults. And we have to recognize that there's an increasing number of not just sickle cell, but of adolescents and young adults with what we would call special healthcare needs, which is to say any disorder or disease in which it requires more than just regular primary care visits. Doesn't necessarily need medicines, but needs some regular follow-up with physicians, psychologists, whatever it may be. And so when we look at prevalence numbers, both in terms of raw numbers back in 2010 and more recent data, the numbers are quite large. So this is not a niche group of patients we're working with. These, the numbers of people who have some need for extra health care continues to grow, and certainly these numbers have gone up since then. So then we have to understand, how are we preparing patients? And I think that's one of the challenges. That's a challenge that's generally put on a pediatric setting. But I'll show you the data we have a lot of room to improve here. Just in terms of some of the larger publications on this, looking at surveys, particularly of importantly, the feedback from patients and families on the transition process. This questionnaire, looking at over 17,000 patients back in the late 2000s, these are the constructs, but it came down to these 4 points. Was there discussion of the adult medical system? What are the healthcare needs, particular to an individual, that are going to change? This was an era, I will say, that was generally pre-Affordable Care Act, or at least in its infancy. So insurance maintenance was a really big issue at that transition point. Now it gets potentially delayed a little bit, but not for everybody. And then clearly self-advocacy is an important part here. So the questions were essentially, how well are these 4 topics being covered? And when it came down to it, only 40%, this was across the board, whatever, if they fit this category of special healthcare needs. And you can see the predictive factors for actually getting this information generally are not things that we would always consider our patients with sickle cell to have. So in other words, sickle cell does have an effect on activities of daily living. Clearly, most patients are not non-Hispanic white. We do have the socioeconomic challenges in large numbers of our patients, and just the other factors that are built in. So it shouldn't be a surprise that not meeting this outcome, the patients who have sickle cell would clearly fall into this category. And then more recent data says that we're actually we're doing worse. More people, the guidance isn't there. And I don't have a slide on this, but there's a different study who's looked at this with similar questions being asked, actually even fewer, but more about the environment itself, parents involved not, for the state of Minnesota. And this 23% was pretty on par. 80% of patients did not meet, they didn't meet this criteria of having a successful transition visit by the feedback of the patients and families. And I think that gets to the point of the metaphor of, if a tree falls in the woods and no one's around, does it hear a sound? I mean, I think that we need to recognize that we may be talking about transition, but if patients and families aren't hearing it, we're not having the effect that we want. That's just the nitty gritty of it, because it's the patients and families who are doing the transitioning. If we look a little bit at history, I'm one who really needs to know, and I think a lot of us should understand the history of what we're taking care of, particularly sickle cell disease. These numbers are probably not surprising to people, but I think it's important to see. So the Dr. Scott article from JAMA on your left, this is one of these sentinel articles that recognize that we have a problem with in terms of sickle cell care back in the late 60s and 70s, where the median lifespan was 18 or 19. You can see on the right, the curve is a little bit flipped from our normal, how we would normally see curves, but the median lifespan is on the bottom, on the x-axis, and the dates are on the y-axis. Here you can see there's a clear inflection point in the early 1970s with the National SCA Control Act. We'll talk a little bit about that more in future slides, but I think that's when things started to change. But I will also say that this curve ends at 2000, and I would argue that as these plateaus go, the plateau is probably vertical, but we haven't seen the same improvement in our slope in these last 20 years compared to this more or less 3-decade period at the end of the 20th century. Here's another looking at the raw mortality. You can see some of those trends shown here, which is to say that with the advent of, this is more or less 1980 to 2010, with the advent of penicillin prophylaxis, with the understanding of implementation of newborn screen and how predictive that can be, and just with general pediatric care improvements in comprehensive care, we saw dramatic reductions almost down to 0 in our pediatric group, but those trends spike right back up and actually surpass in these adolescent and young adult group. And if you look even at the green and purple, while there aren't big years, year stratifications, you can see that actually we arguably made a little bit of a recession in terms of the median lifespan, where that 45 to 54 was our peak threshold in the 1999 to 2003, and there was actually a slight move backwards for the purple. And then comes what we think about and see most often, which is the healthcare needs. I think most people recognize that patients with sickle cell disease in this adolescent young adult group, which is 18 to 30, call it, or in this case 15 to 30, has a high burden, but it's a burden that is both specific to sickle cell, but also specific to this disease compared to others. So this National Research and Quality Database survey, in which sickle cell was the diagnosis for a quarter to 20% of patients, and with comorbidities that we're typically used to seeing. You can just see visually our patients with sickle cell anemia were on a totally different curve, much higher rates across the board than other diseases where maybe people weren't born with it, like diabetes, but clearly have an increased need over this lifespan. This just kind of shows that the 30-day unplanned readmission rate is extremely high. I will also point to the first point underneath, which is to say that really 28% of patients had 4 admissions within a month. And what I think we as providers see that is one of the more challenging components of this is, which is a quarter of these patients were going to different hospitals. And that is a reflection on our medical system, on ourselves, and building trust in systems that patients will come back. They're not going around just for the sake of it. Patients are going around because they're looking at, where am I going to get dignity and respect in my care? Where can I get people to trust me? They will drive further to get the care that they feel like they deserve. And I think that is a reflection that we need to work on. Just looking at it in sickle cell disease, again, here again, you can see that the adolescent and young adult group, while kind of in a third of the percent here were also the peak utilizers, and if you were on public insurance, that rate increased by 40%. And here again, the rehospitalization rates are quite high, and I think that really is also an important thing for our systems to understand, because they don't get, if somebody's publicly insured and has a rehospitalization, they're not going to get reimbursed. And so this is not just a hematologist issue, this is a systemic and healthcare system issue that we need to be aware of. And then we talk about coping and how patients cope And I think this is I want to take a little time here just to recognize that we need to understand how patients are dealing with their disease, how patients are dealing with their stressors, both within the medical system and without, if we're going to make any changes. And these are having the explicit discussions. I had a patient who I met for the first time this past month. She told me, in perhaps some of the clearest terms I've heard, what pain, that there's a difference between her pain that she has every day and her sickle cell crisis. And in other words, she knows she has these aches and pains and understands that she has sickle cell every single day, which is not true for everybody. And I asked the question, do you have pain every day? But she says it's different. Sometimes I just know I have it. Arguably, you could say we hear that sometimes with elderly folks and osteoarthritis. I know I have it, but these are patients who are in the prime of their lives, and it feels different when it's the sickle cell crisis. I know it's different, but they don't come to the emergency department because of the stigmatization, and particularly that point about unwillingness to see the disease, how it's affecting them individually. And we have taken that on, particularly at our system, and when we have a pain plan, which we have for everybody, because I think it's important to try to standardize some semblance of care for everybody, and it expedites the time they can get medicines. The first part of our pain plan, other than saying when we reviewed it, so that we know it's updated, is this is who they are that has nothing to do with their disease. For instance, a 22-year-old who works as a medical receptionist, or who paints, or who plays basketball, whatever it may be. Because I think if we're not recognizing people as individuals, we are not recognizing them as patients. We are giving them the title of sickle cell disease phenotype X. And I even have to catch myself, but I think I'm trying to work as a culture to say, we don't say sickle cell disease, sickle cell disease patient. We say the person with sickle cell disease, because we need to stop the labeling, even if subconsciously happens when we put sickle cell disease in the front, and it doesn't help anybody, because it generally has a negative connotation. But I also, and I think for all of this, I will say trust is the most important currency we have for care for sickle cell disease, and transparency as well. And it kind of gets back to that 25% showing up at different hospitals. The best way we can standardize care is actually making sure patients trust us, that they know that we're being genuine, that we're going the extra mile and working at a systems level, so that everyone is seeing them. And this has been shown. There's a recent study out where looking at patient activation, which is in some ways it's a step above patient engagement, where it's just knowing about their disease or coming to their appointments. It's actually taking hold of it and being a collaborator with their own care with the providers. And that comes with trust, and that comes with transparency. And that takes time, but we have to do it, because and the data shows that the healthcare utilizations drop, which is what we need. Then of course, COVID enters the picture, and it makes things a little bit rougher. We're talking about now, as of yesterday at least, 1.7 million in the US. We've hit that 100,000 death mark, I think at 101 now. In Minnesota, we have 23,000 change people with COVID, and we hit we hit the 1,000 mark, unfortunately, just yesterday. This is data updated, as Dr. Andemariam said, they update it weekly. This is from that Secure SCD. And the curves are pretty similar. You can see that this adolescent young adult group, at least by reporting that's going through their database, is still the ones most affected here. I don't think the death rate has changed, but everything is generally affecting our patients. And I'd say that the CDC, I think, said that about 26% of patients are Black, and that's only 13% of our U.S. population is Black. So that's again, this is affecting our patients. Even if it's not affecting them directly, it's affecting their families, it's affecting their friends. And it's also affected our healthcare modalities. You know, I think that these are challenges that are not just local, but I think we see them, we are acting on them. One of those particular transitions is that the planning is delayed. Children's, which has a very robust transition program, as an example, talking to their providers. You can't do comprehensive clinic visits if you can't come into clinic very well, particularly with rehab if needed and the other things. And so that's been put on hiatus. I think they're starting to get back into it, but clearly not going to be the same as before. We've had to delay or cancel visits. We've had to postpone surgeries and specialty visits. I can speak to even some of my young adult patients where they really need, shoulder surgery, or a patient who has had recurrent pain crises that have been associated with tonsillitis and needs her tonsils out. Those are actually directly affecting her disease-related morbidity. But we can't, at least at the university, all surgeries have been on hold until the last week or so. And then this access to care and virtual resource inequities. Dr. Andemariam referred to it a little bit, but we definitely are seeing this. We have patients who, they don't have free data. They don't have the ability to get apps. They don't have the computer access to be able to do this. But it also, we're hematologists. We need to look at labs. That's just part of care, standard of care here. And so actually what I've felt really magnified is the fact that our patients are actually extra burdened, arguably more than providers are burdened here. Because if we need to get labs, they have to then add a second visit to a lab or wherever the system is allowing labs to be drawn, separate from the visit, unless they're actually happening at the same time. Whereas before, this is, kids and adults, before we'd get the labs while they were in. So this is actually adding significant burden here. But we can't disregard their care and just not have a visit because of it. So we're figuring it out. And I say that because having talked to other providers in the community, we are rising to the challenge. We're going to take advantage of the fact that our pediatric centers, Children's and Masonic, have lengthened their admitting age to 25 years. And, that was done to decrease the burden on adult ICUs, but it's across the board. And so we don't feel that sense of needing to push the transition and make it happen when they turn 21 in the same way. We've been doing clearly virtual visits as much as possible. And I've done several first visits at transitions because of this, because I feel like if there's, and trying to do video if possible, because even though there's not that therapeutic relationship and bonding happening because we're in the same space, there's at least a visual recognition and an ability to emote in a different way than can be done on the phone. So we've tried to do that. I have increased my, kind of phone calls to patients, et cetera, not for an official visit or anything, but just to recognize that COVID itself has been isolating. This week, in Minneapolis and really around the country, as we're seeing, has been extra isolating, particularly for patients with sickle cell. So just checking in and knowing that we're there, I think, is really important, in making sure that with all of this, that they're not being forgotten. I think on the new drug options, particularly hydroxyurea, for instance, and L-glutamine and penicillin for our kids, those things are more easily prescribed remotely. We've taken the stance on things like crizanlizumab, where we have, half a dozen patients or more on it now, that we're going to stay on it because we feel that one is a preventative medicine and hopefully keeps them out of these acute visits, but two, it's a more controlled environment than the ED. And so if we can do the same screening we would do for everybody, but actually get them in for this infusion clinic, there's somebody, laying eyes and making sure that everything is covered. But it's going to, the whole goal of them being used, and voxelotor as well, although maybe not as helpful for pain, is to keep people healthy, to keep people from needing transfusions and coming in with crises. So we've stuck with them. I think that wasn't the case for every center around the country, but it's all evolving. And lastly, I will say for the university, where hospital medicine manages inpatient care as the primary service, and our ED obviously is the front line, they were also front lines for COVID. And so there was clearly an important need for them to change their focus. But as things have stabilized out, there's been active engagement to reach back out and say, we cannot lose the steps that we had taken, installing pain plans, to understanding the give and take of hospital medicine primary and hematologist consult, and the quick access to pain medicines in the ED, for instance, because all of those strides can very easily be lost here, as well as at a systems level. It took the action to reach out to the leaders when there was going to be reductions in opioid availability or blood transfusion availability, and saying, you cannot do this for sickle cell. We already are dealing with patients not getting access to the same amount of care, and now you're going to deprive them of standard of care. That doesn't work. And so we did step in, and thankfully people heard those voices. So then, talking about bridging the divide, in this last section, this is something that I talk a lot about with patients who are transitioning, particularly at the first visit. I generally try to use this metaphor of, kind of this suburban connectivity of pediatric care, this healthcare home model where everything is really close. It's kind of a hub and spoke, but those spokes don't go out very far. People understand how to navigate it, whether it's providers or families or patients. And it feels very close-knit. Even the other specialists we use often have a really tight understanding and a connection with the sickle cell care team. You can't put that into the adult infrastructure and expect it to be sustainable as is, because the adult infrastructure runs in these parallel superhighways of specialty care and maybe or maybe not having primary care. But my experiences, both in training, but also in my work now, is that there aren't the same sort of connections with the adults, the other specialists with adults. There certainly aren't the same amount of resources, and everything is moving at a pace of caring for, say, arguably the 40 to 60-year-old patients who have been adults and independent for, several years or decades of their lives. It's not meant for people who have had a lifelong disease and gotten the same really tight-knit structure of care for 20 years. I feel pretty strongly it puts our patients at a disadvantage unless we discuss the expectations, but we also have to act on them. Because I think that when we talk about transitions, we're talking about this well in advance of, say, age 21, even for the whole decade before that. And you kind of get up to this mountaintop and it feels like a cliff, and as it gets closer, there are a lot of young adults who don't want to take this jump. And the reason is because we're only halfway there. And so we have to sort of think of transition as there's a separate curve on the other side. And arguably that curve has to be just as long. It's more than just coming and getting into the front door of our clinic. It is a relationship building. It is a subtle downslope that will take years ultimately, but without a thought process in that and having the structure to do that, we're not going to be able to provide transitional care. And as was said previously, patients can kind of lose that connection with the medical system pretty easily for lots of reasons, particularly because they're living more independently, perhaps try to have jobs or get their education, et cetera. These things can be lost in a way that wasn't being done when their parents were having them come to the clinic. So we need to think about that structure as really being a bell curve. There are lots of ways to do that. This is a paper from Dr. and actually many of the ones, as I saw the names on the list of those with the Medical and Research Advisory Committee that Dr. Andemariam described, and she's one of the authors here. Lots of different curricula for this transition, as well as just systems of connectivity between pediatrics and adults. But that said, there are obviously advantages and disadvantages to all of them. Just because you have a robust pediatric center doesn't always mean that the adult center is working just as robustly. I felt that, at least on the pediatric side, in my fellowship training. And so those are things that I'm acutely aware of and trying to bridge. And I would also say that different, as I was, a year and a half ago now, when I was looking at this position and thinking about it, even before I started, I called half a dozen people, including Dr. Roberts up at Yale, who's one of Dr. Andemariam's colleagues, and said, how do you guys do it? All the leaders, different places, whether it was Hopkins or UAB and the others. And I found that there are, for talking to say 6 different people, there are 6 different ways to do it. And I think that is important, that there's trial and error, but that you have to work within the system, and guidelines that are out there are really helpful to kind of get a first step, but they only go so far because they may not work for your environment. And so here's an example of that for our Twin Cities community. We have 1,000 square miles of metro here. And I would say the vast majority of patients with sickle cell live within this. There are some that live up kind of northwest of the cities a little bit. The circle dots, these were data that I ran back in turn of the year. This was just from the mHealth Fairview adult side, but kind of where do some of our zip codes cluster? And how are they in relation to our geographic medical centers? And these are the centers, I should say, that do focused sickle cell care. There are other healthcare systems out there that don't do it. There are other hospitals within our systems, particularly mHealth Fairview, which has, I think, 7 or 8 different hospitals and several different clinics. Not everyone actually most others don't have a focused benign hematologist there. And so we have to think about this in the structure of this triangle, as I'm showing here, is where the focus of our sickle cell care is, particularly for transitions. So we've integrated PCPs, but we're still missing a big potential geographic swath, and we have to make care accessible. Also thinking about our system, at least at the hematologist perspective, this is how the transitions work in kind of a schematic. Children's has about 80% of patients with sickle cell, kind of our children and adolescents, whereas Masonic, which is mHealth Fairview's pediatric center, has the other 20%. But that's a big change. Children's Adult Center doesn't actively take patients with sickle cell disease. So they come to the university where we have 6 benign hematologists, actually I think 7. Hennepin has a couple. And so Hennepin being the county hospital for Minneapolis, there's a pretty equal split there, and then a smaller bit that goes to health partners, with a larger component of health partners, primary care being focused on sickle cell. But these are all, except for the small to big mHealth Fairview, these are all different EMRs, actually even Cerner to Epic in some cases. The EMRs only talk so well. But there's big transitional gaps here. And so, like I said before, in terms of you have to think about your environment, we have a very competitive healthcare environment in the Twin Cities, but that doesn't mean it's competitive or equitable for sickle cell care. And so we have to think outside the box and figure out how to build these transitions. And when I came, I actually, aside from just the ease of staying within one system, I felt like it was important for me to be truly an adult hematologist for the 80-ish% or so that might transition to me or our group, but with a full understanding and active engagement with the pediatrics understanding, so we can hybridize that approach. Different places will look at lifespan care or whatever. suits their needs best. This is the approach that I felt like was most important, to give young adults their independence and recognize them as adults and not just in a pediatric center. But I think people will find that that mentality may differ at least slightly, or there's different approaches in different places. What we've decided to do here, and I will admit this work was being done to some extent before I started, but we really tried to consolidate it and have me be a focus on it, which is this Patch SCD program, which is promoting transitions, particularly as we talk about it across different healthcare systems. And that means that as a group, and I think we all have very good relationships, and we have, Ray is involved with this both in her role at Children's, but with the SCFMN, that we have to be in this together. And that means trying to standardize care as much as we can, but really engage with each other, engage with the community, and evaluate ourselves on a continual basis with quality metrics, and so that there's no room to be, to kind of sit back on any kind of laurels, that we have to keep acting. So we talk about the hybrid, some of which is, pulling from the pediatric approach, but giving people more independence with their own care than they often do in pediatrics. And then thinking about it as a safety net, so that if we are, particularly if we're talking about healthcare maintenance, we don't have any, in the adult centers, any primary care directly integrated in our clinic. So we work with our community members, and that's even across healthcare systems. Actively, I know people from my training, for instance, that have expressed interest in sickle cell care. I'm not just going to send people to just any PCP just because I feel like they need it. And I do think they do, because things like reproductive health are not issues that hematologists are experts in many cases, but are also not things that were generally covered in pediatric care. But there's other things that come up. There's occupational health, those types of things, that having a multi-headed team may, in our case at least, means reaching outside of our clinic and building relationships so that patients can have, if nothing else, a second point of access if they need it. It means community engagement, obviously with Sickle Cell Foundation of Minnesota, but also with our MDH, who has a grant from the CDC to build surveillance, so that we have a better understanding of our numbers. If we look at our newborn screening, we would say that there's about 2 or 3 dozen children born in the state each year with sickle cell disease, but we also have a lot of immigrant population, particularly from West Africa, who don't get newborn screening, who may not know. I had a 19-year-old who found out, she moved from Liberia, found out when she was pregnant, once she moved here at age 18, that she had sickle cell disease. Those are the types of realities that we deal with, and we have a heterogeneous population here. We think we have somewhere in the range of 200 adults that we have regular engagement with, but certainly there are more patients out there. So we're working with MDH on that. I talked a little bit about building a PCP network. We've discussed a tiered approach, which is to say there are some patients who really need tight-knit hematologist involvement. There are others who don't. There are others who are very independent, who haven't had a pain crisis in years. It would be really helpful to be linked in with a PCP, and then maybe see a hematologist and PCP alternating, but not have to be in the specialty clinic at all times like they were in pediatrics. And then thinking about our trainees and reaching down and educating people early, both with to generate interest, but also with the fact that they are taking care of patients inpatient. And many will become hospitalists within our systems, and so we need them to know how to take care of sickle cell optimally. And then thinking about innovative care approaches. Now, I think the slide was made last fall before we all got forced into telehealth. We were actually making, I don't think any of the systems had active telehealth here, but we were talking about it. If I have a patient who's got a stable job, well, the last thing I need them to do is take 2 to 3 hours to drive across town from St. Paul to Minneapolis to come to our clinic, to, be physically there all the time. That can happen some, but if I can work with them, even if it's to a different hospital system, but much closer to their work, I've saved them hours of lost time in transit and the like, and cost. And so those are the types of things that we were thinking about. We've all been forced into it now, and I think we're seeing both the inequities that I probably did not appreciate to the same extent. But I think we're learning as we go, and so I do think this will become a component to some of our care going forward. And then thinking about how are we doing and how can we do better. Building our database, particularly with the new therapies, and understanding their utility and their side effects, and thinking about how are we using them best. Expanding our research, both with pharmaceutical industry, with nationwide studies through our efforts to be in the ASH Research Collaborative. I had a local study with Dr. Lixon, who's a primary care doctor, to build a patient advisory board kind of trial with a multimodal approach, so that we were, so our young adults could help guide really the care for the whole sickle cell adult population that would be at our centers, by integrating with primary care, by understanding their feedback and seeing if their recommendations work. Because again, I don't want to just assume that what works somewhere else will always work in our center. That's been on hold because of all of our research restrictions at the university with COVID, but hopefully we'll get there soon. All this is to say we're working on making sure that there's no settling here. We're not just going to say, oh, we put in something for sickle cell care and that's enough. We have to keep improving. We have to evolve, and we have to have a larger part, and be a component of our care needs to be part of the national studies, because we, arguably our environment is different than other places. And so just because a therapy works or a plan of action works in Atlanta doesn't necessarily mean it's going to work in Minneapolis. And so we're kind of working on that part. And then lastly, in terms of self-advocacy, clearly that's a huge component here. This gets back to that patient activation, both in the medical side, but clearly with reaching out to the community in the non-medical side. Sickle cell disease affects their lives on a daily basis, and it's not always just in the realm of their medical care. So we work on engagement with policymakers, and continuing to move that forward. So as I finish up, clearly the sickle cell population, particularly those of adolescent and young adults, are growing. I know that we have about a dozen new adolescent and young adults in our university system just since the start of the year. But we're building, there's some trial and error, we're building our clinics, and we're having to work with both the current infrastructure, but also the realities of transitioning across healthcare systems. And so we're gonna work with what we have, and we're gonna make it better. And that means teamwork, that means community approaches, and that also means evaluating what we're doing and trying to improve it there. And so then I'll finish with just this kind of metaphor, this Midwestern metaphor of the field of dreams, but I'm flip it on its head, which is to say, this isn't an if you build it, they will come. This isn't they are coming, so we have to build it. And so that's the approach we're taking. And with that, I will finish up. Actually, one more thing before I get to that. For some additional resources, these are some of this is history. Like I said, understanding how we got to the point we are now is important. I would encourage you to read this book about the Black Panthers grassroots efforts. I talked about the National SCA Control Act. Much of the work was actually done at the grassroots by the Black Panthers, a story that doesn't get told. And the government and Richard Nixon essentially co-opted their work without the recognition. But they were pushing this well before it became a national thing. Keith Wiley's book on history of sickle cell and race and health is important. This, having grown up in Memphis, this also hit home because I lived and trained and worked in some of the hospitals talked about, but it's a bigger picture about it. And then I'll also point for the podcast audience here, listen to the realness. This is about the life and death of Prodigy, a rapper who had sickle cell disease, who died of a crisis at age 42. And I'll particularly point to episode 4, and there's audio in there from Dr. Wally Smith at VCU, who's a leader in this community. But it really highlights what we say and what we write in a chart, for instance, can have residual effects and really colors the medical racism that we see. So this is another good audio that an audio option to take advantage of. So with that, I will hand it back over to Ray.
Thank you very much, Dr. Boucher. Making sure that everyone can still hear me. Okay, we're going to move right along. I just want to remind everyone that these sessions are being recorded. The plan is to upload them to our website and eventually to a YouTube channel so that they are accessible. We're also doing Facebook Live so that others can have access to it in a forum and a manner that works best for them. So thank you very much to all of you who have joined us. Please continue. We have one more short presentation, and then we will take questions and answers after that. Please type your questions in the comment box, whether you are on Facebook Live or you are in Zoom. Type your questions. We will respond to them, ask them at the end so that they can be answered. Okay, next up is Hailey Hassell. And Hailey received her Master of Social Work degree from the University of Minnesota School of Social Work and has been a member of the Be the Match Patient Support Center since 2018, providing direct one-on-one support to individuals along the transplant continuum. Their caregivers and the sickle cell disease community. She has experienced in-home care and hospice coordination, as well as provision of mental health services. Hailey is a member of the Association of Oncology Social Work and a member of the Association of Pediatric Oncology Social Workers. Please welcome Hailey Hassell from Be the Match, who will talk about their new program offering counseling services to the sickle cell disease community. Hailey, you are up.
Excellent. Good morning, everyone. I'm going to share my screen. Ray, I think that you'll need to re-grant me access. I was momentarily kicked out of the Zoom meeting. So once I have that, I will be able to pull up my slides for you.
Okay, you should be good to go.
All right, excellent. All right, well, good morning, everyone. As Ray said, my name is Hailey, and I am a social worker in our counseling services department at Be the Match. And I'm here to talk a little bit about the emotional impacts of COVID-19 that we here at Be the Match have seen, as well as discuss our expanded support services to support both individuals and families impacted by sickle cell disease. Before I get started, before we even start diving into this topic, I do want to as well touch on the topic of George Floyd's death and what has occurred this past week in Minneapolis. And this has, of course, impacted our Minneapolis community, the Black community, and for so many, it has shifted the focus from the pandemic to this tragedy. And there's a lot of grief and a lot of very just anger. So particularly when I'm talking about the emotional impacts of COVID and the grief and community trauma that is occurring with the pandemic, that also applies to the emotions and responses to George Floyd's death that we have seen across the nation. So I recognize that focusing on the emotional impacts of COVID may not be the top priority at the moment, but my hope is that you can take what we talk about today and apply it to where you need it to take care of yourself and your communities. So for this portion of the webinar, we're going to spend some time discussing the impacts that COVID-19 has had on the sickle cell disease community with an emphasis on those emotional impacts. We'll then explore several practical strategies to mitigate these emotional impacts and dive into some self-directed tools that you can use or that you can give to your patients and their family members to help manage the uncertainty with this time. And then I'll take some time and review the Be the Match resources that we have expanded to support the sickle cell community. So in one way or another, we have all experienced changes to life as we know it as a result of COVID-19. I know that that is not new information to anyone on this call right now. But with that being said, there are experiences and challenges unique to those in the sickle cell community. And as Dr. Andemariam acknowledged, systemic racism, difficulty accessing care are all experiences that are far too familiar to the sickle cell community. And they're also key elements as to why individuals with sickle cell disease are experiencing this pandemic differently. So when looking at the impacts of COVID-19, it can be helpful to separate the practical impacts of the pandemic from the emotional impacts. By identifying whether a challenge is a practical one, it can be easier to navigate the actionable steps and solutions to resolve this challenge. And then conversely, if you identify that a challenge exists because you are feeling overwhelmed, you're feeling anxious or unsettled, oftentimes naming that emotion is the first step in addressing your heightened emotions. It's also, of course, important to acknowledge that these challenges are not siloed and are oftentimes cyclical in nature. So for example, if you have increased anxiety related to the pandemic, that may be clouding your ability to think as clearly as you normally would. And it can make something that you do routinely, such as calling your pharmacy, calling your clinic, it can make it much more challenging than it would normally be during this pandemic. And then on the other side of that, not having a clear understanding of the safety protocols of your clinic may perpetuate your anxiety. So by taking some time and naming these impacts that you've experienced, it can be easier to prioritize your needs and then manage your health. So turning back to the specific impacts of COVID-19, here at Be the Match, we've heard several various themes emerge for people with blood cancers and blood disorders and what their experience has been over the past few months. Some of these practical challenges include transitioning to virtual appointments and the technology challenges that may coincide. And for those who continue to have in-person appointments, changes to clinic safety protocols, such as not being able to have a caregiver or a loved one join appointments, has been a common experience. And another frequent challenge that individuals with blood disorders or cancers have experienced is challenges with getting extended prescription refills as to avoid multiple trips to the pharmacy. And there, of course, have also been major financial implications as a result of the pandemic. And so now if we change lenses and turn our attention to the emotional impacts of COVID-19, we have really observed an overwhelming increase in anxiety among those within the sickle cell community and those with other hemalignancies. So you may have been experiencing increased anxiety related to exposure or infection, or perhaps your patients are vocalizing this anxiety. And with that oftentimes comes hypervigilance. It tends to put our bodies and our emotional responses into fight or flight mode, which is not a sustainable way to continue forward. You can't maintain that response for significant amounts of time. And perhaps you are finding yourself unable to enjoy things that you previously did prior to the pandemic, whether it's spending time with family because it's dangerous. Perhaps you're distracted and you can't enjoy different hobbies or activities the way you previously did. And again, I want to touch on that isolation. Many with pre-existing conditions have also found themselves feeling more isolated from their support systems and community, not only with stay-at-home orders, but also the heightened risk of exposure and being immunocompromised. It's been very dangerous for people to leave their homes. There's been a lot of fear around that, and people are retreating. And they're not making the outreach in different ways, such as calling people, such as video calling them, because that's not necessarily part of their repertoire and how they connect with people on a day-to-day basis outside of a pandemic. And then alongside that isolation, we've heard many people voicing symptoms of depression. So again, that's feeling down for the majority of the day or having lack of motivation and very often a lack of hope for the future. Very hard to see the end of this pandemic, even with states beginning to open up. For those with sickle cell disease and their loved ones, that's not necessarily the next steps for them. So if you find yourself experiencing these symptoms of depression, or if you're hearing it from their patients and their family members, that is such a key element that they are in need of additional support. With that isolation, it's so important to remember that they may be going through this experience on their own. They may be living on their own, or they may only be seeing a few family members each day for this extended period of time. but there are so many within this community that are experiencing similar effects, and getting that support is crucial for this community to take care of themselves. And now I want to touch on just two bigger themes that we have observed that have been just very pervasive, and they will likely carry on for quite some time as a result of this pandemic. And first off, I would just want to touch on the experience of grief. And this pandemic has brought immense loss in many different senses, whether it's loss of job security, financial stability, human connection, and routine. And this is all on top of the loss of life due to COVID. And if you haven't necessarily experienced these losses directly, but you still find yourself carrying that very heavy weight of grief, you're still experiencing those emotions, that is what we call anticipatory grief, which is your emotional response to impending loss. And then finally, I just want to touch on the prevalence of community trauma, which is the longer lasting community impacts of the pandemic that will likely carry on for years. There will likely be heightened anxiety for quite some time, even as the pandemic begins to settle down and perhaps as the vaccine moves forward. We will very likely find that individuals in the sickle cell disease community will have that anxiety, they will have that depression, and they will continue to self-isolate long beyond when they need to, simply out of fear, and because this is the pattern and because they've been stuck inside that fight or flight response for so long. Okay, so with this increased stress and anxiety associated with COVID-19, it is important now more than ever to be checking in with your loved ones and also be checking in with yourself and find ways to reduce anxiety and maintain healthy emotions. So similar to the prior slide, how I broke up challenges based on emotional and practical challenges, it can also be helpful to break up strategies to mitigate these challenges based on practical and emotional avenues as well. So for many that are experiencing this heightened stress and emotions associated with COVID-19, figuring out what you exactly are, you're thinking and you're feeling, what exactly the true challenges and the true barriers are, that'll help you break down the practical tools that you need to move you towards a solution. So again, you go back to some of the prior examples of needing to go into the clinic for appointment or needing to figure out how to get extended prescriptions through your pharmacy. Using practical tools and just very stepwise methods to break down these barriers will then in turn reduce overall stress for you as well. So a few examples again, if you turn to your clinic or your hospital system, wherever you are needing to still get in-person medical care, changing their practices for safety reasons, it can be so helpful simply to call ahead and ask what to expect. Will you be allowed to bring a caregiver or a loved one? Will you get PPE at the door? Will they take your temperature at the door? Simply getting that knowledge and preparing yourself ahead of time will greatly improve your anxiety levels and make you feel more prepared going into these appointments, which in turn then will likely create for a better appointment. You'll be thinking more clearly, you'll be able to ask your doctor or provider the questions that you need answered versus trying to manage that stress that you've been experiencing. So an additional way to manage stress throughout this pandemic is to really tune into your emotional and mental health needs during this pandemic, which can be a new experience for many people, trying to be perceptive of the emotions that you're feeling and why you are feeling them, and then take those next steps that perhaps you're not familiar with, whether it is that mindfulness, meditation, some of those bigger classic coping skills that we hear out in the media so often. But the ways to reduce the overall feeling of isolation is to start by talking about it with your loved ones. Once you realize what you are feeling, don't be afraid to reach out to support. And if you find yourself not getting the support that you need, whether it's from your family members, your friends, your community, that is an excellent time to reach out for counseling, which is truly meant to be a dedicated space for you to process your experience. It can also be helpful to find a mantra or different words of encouragement to repeat to yourself when you are struggling to slow down your thoughts. So a few examples of this would be to repeat to yourself when your mind starts racing, when you're getting really caught up in the pandemic and really struggling to quiet your thoughts, is to repeat to yourself, I am safe. Or you can even use the phrase, I am doing all that I can to keep myself healthy. An additional way to manage your emotions and your thoughts related to the pandemic is to practice mindfulness, which I'll talk a little bit more in the upcoming slide because I know it can oftentimes be a new avenue of support for people, and it can be a little intimidating to get started with. Before I transition to that, I will leave you all with just one small act of mindfulness that you can begin today, is to simply begin bringing your awareness to the negative or the anxious thoughts that you are experiencing throughout the day. So often we are giving ourselves the same messages over and over again, the same worries, the same thoughts, and we're not even aware of it. But that's, again, sustained messaging to ourselves. It really increases anxiety, and it makes it a lot harder to manage your health, to manage your emotional health, when you're not able to separate yourself from it. All right, so now we will shift our attention to focusing more on mindfulness for the next few minutes. And mindfulness is likely a term that you have heard before. And in the simplest of terms, mindfulness is a collection of strategies that can help you feel present in the current moment. So these tools, these exercises can be helpful in taking one day at a time or one moment at a time, which is really crucial right now in the midst of this pandemic when there is not necessarily an end in sight. And the goal of mindfulness is simply to bring your awareness back to the here and now, and in turn, that oftentimes reduces those anxious feelings about the future. And there are many different ways that you can practice mindfulness. There are many different ways that you can get started practicing, and it often does take some time and a little bit of creativity to figure out what strategies work best for you. You know, I often tell clients that I'm working with it's kind of like digging around in a toolbox. You're trying to find the right tool that you need for the specific project, and perhaps you find something that's similar to what you need, so you try and use it. It kind of gets the job done, but not necessarily. And you have to keep digging. You have to be patient, which is really hard to do. So the first exercise that I'm going to touch on as an example to practice mindfulness is to engage in different grounding exercises. So grounding exercises often involve bringing your attention to your physical body and your environment. So an example of a grounding exercise would be simple breathing exercises or breathing techniques. And if you're sitting in a chair or if you're lying down, a really easy and simple way to do this is to make sure that both feet are rooted on the ground and you're just taking deep breaths in through your nose and out through your mouth. There are also certainly several different breathing patterns that you can engage in. I would be more than happy to talk about those if you are interested. I have our contact information on the final slide of this presentation, but can be just really great strategies to practice, and they're also very easy to do self-directed. Another way to practice mindfulness is to have a sensory experience. So this is truly engaging sight, smell, taste, touch, all of that, to really distract yourself in the moment and re-ground you on where you are. So a great way to fully engage your senses can be, for example, by cooking your favorite meal and then just focusing on that experience from start to finish. So taking that time and really smelling what is coming off of the stove, or perhaps feeling that heat rise from the pan, listening to the sounds that the food is making inside the pan. And by immersing yourself in these sensations, it'll help bring your awareness back to the present moment. And there are also guided practices that can lead you through mindfulness exercises. I'm sure many of you are aware of the different apps and online tools that can help get you started. But what I really do like about those is that oftentimes it guides you right through it. So you close your eyes, you find yourself in a comfortable position, and then audio will walk you through how to practice mindfulness, how to practice meditation, or perhaps do that guided imagery exercise with you. And as I mentioned previously, it can take some time to find the right mindfulness exercise that works for you. And even then, it does take time practicing it to be comfortable with it and to reap all of the benefits of mindfulness. So the more that you practice mindfulness, the more comfortable you will be with it and the more effective it'll be. I oftentimes also like to think of mindfulness as a muscle group that needs to be exercised consistently to strengthen over time. So now we've talked about some of the major emotional impacts of COVID and the strategies to reduce distress. I want to shift our attention to changes within the Be the Match Patient Support Center that we have made as a response to the pandemic. So historically, our patient navigation services have been for individuals and families along the bone marrow transplant continuum, which is not always the treatment trajectory for those with sickle cell disease. And so with that, we have not served this community in the way that is needed. And because of the immense impacts COVID-19 has had on the sickle cell community, we are now opening up our navigation services to individuals diagnosed with sickle cell disease, regardless of if they are going to be pursuing transplant. So we have patient navigators with varying backgrounds. Many are nurses, many are social workers. We have a few child life specialists as well. But they are all available to help you navigate the healthcare system, to help you find clinical trials if that is something that you are interested in, to answer questions and provide education about your diagnosis, and to also connect you to very practical things such as financial resources and help with transportation issues to and from your clinic. So again, I have the contact information on the final slide of my portion of the presentation, and I would really encourage you to reach out to us directly or direct your patients to us, because even if we are not necessarily the right people to reach, our patient navigators will take the time to make sure that you and your patients, you get the resources that you need and you're sent in the right direction. An additional service at Be the Match that we are extending to the sickle cell community is our free telephone-based counseling. So that, again, that is the work that I do alongside several other colleagues. And should you find yourself needing more intensive emotional support, our licensed clinical social workers are here to support you with whatever emotional challenges you may be experiencing. And this counseling service is very similar to traditional therapy appointments, where you would have weekly 50-minute appointments for up to 8 sessions, and everything discussed in counseling remains completely confidential. So you would work directly with your social worker to define specific goals that you have for counseling. So again, perhaps it is addressing anxiety or depression. Perhaps it's finding practical ways to manage your health or working through family dynamic challenges as a result of the pandemic. Whatever it may be, I would again encourage you to reach out and we can talk through if this is the right avenue of support for you. And then the final resource that I want to touch on today is our new COVID-19 financial grant that is available to support patients who have experienced financial impacts as a result of the pandemic. For example, a loss of job or a loss of hours. And this is a one-time grant that is available for anyone whose doctor has requested a formal search of the Be the Match registry for patients pursuing a bone marrow transplant as of March 1st, 2019, or for those who have had a transplant as of March 1st, 2019. So if you are working with patients with sickle cell disease, if you yourself have sickle cell disease, and transplant is potentially a treatment option for you, you could very well qualify for this event, this grant. And of course, if you have had a bone marrow transplant, then you do qualify for this grant. And if you are uncertain if your provider has requested a formal search of the registry, you can call us at the Patient Support Center and our navigators can look up that information for you. All right, so I just want to thank you all again for joining this portion of the webinar. I recognize it's hard to take the time to focus your attention on these emotional impacts of the pandemic, just given the current climate. I know it's a Saturday, I know it's early, so I just really appreciate you being engaged. And again, I would just encourage you to give us a call or send us emails with any questions or needs that you may have. We are here to support you, and we will make sure that we get you to the right person if we are not that person that is offering the right avenue of support. And with that, I'll turn it back to Ray.
Thank you so much, everyone. I'm so appreciative to everyone who is online via Facebook Live or through our Zoom meeting. I want to ensure that you all know that this is a monthly webinar series that we are offering virtually, SickleSMARTSummer. I am trying desperately to share my screen so that you can see what we have coming up each month. Next month is our next session takes place on June 27th from 10 a.m. To 12 p.m. And Dr. David Wood, who is a researcher at the University of Minnesota, Dr. Stephen Nelson from Children's Minnesota, as well as Dr. Jed Gorlin from Memorial Blood Centers. They will each, again, as experts in their field, talk about sickle cell disease and managing care. Next up is the Q&A questions. We've had a couple of questions that have come in. The first question that is being asked is, how do we as caregivers know the difference between some of the symptoms? And then who do we call first? Our hematologist clinic or our primary care providers clinic? Can one of our providers answer that question, please?
Dr. Boucher, since you're local to Minnesota, maybe you should take that one.
Sure, I would say that from the standpoint, the easier question is the contact, I think, which is to say, you should contact the hematologist, honestly, because I think we're probably, I'm not so sure about the access to primary care providers, particularly because they may be co-opted into COVID care. I know that, for instance, Dr. Blixton has got some coverage coming up. And so I think just from the access point of, we as specialists are on call, all the time, or have our nurse care managers available. Call us first, help us, we'll help you navigate. Particularly, certainly you're going to be calling because there's an acute issue, which we're used to managing anyways. I think that's the avenue to go. And then, for the kind of crossover symptoms, Dr. Andemariam pointed out pretty clearly, it's very difficult to tell, particularly in terms of acute chest, but also just the fact that we know many infections will trigger pain crises or trigger other infectious symptoms. I can't speak for Connecticut, but here we are, or other states, but here, most of our centers, if you show up to care now, you're going to get screened, and with a pretty quick turnaround in time. So we're going to treat it as it's sickle cell associated care, but we're going to know much more quickly than perhaps even a few weeks ago whether you have COVID or not, and we'll manage the care as we go. I think we all as providers are still trying to figure out how this will fall out, but certainly there's overlap in the same way there's always been overlap with sickle cell associated complications. But the most important thing is that we know you're having them. And as was pointed out in the first presentation, if you at all can manage it at home, call early. Let's see if we can help you manage it without coming to care. But certainly having these complications at home without anybody knowing does nobody any good.
Thank you, Dr. Boucher. Another question that we have is, how do early discharges impact readmission numbers? And I think what they're getting at is the sometimes rush to discharge. And then you end up back in the emergency room with people who don't know your care, don't know your plan, or don't follow your plan. Is that taken into consideration in some of those readmission discussions?
Well, I'd be happy to touch upon that. If this question is specific to sort of the COVID pandemic, I'll acknowledge it is an issue in the sickle cell community across the country, where oftentimes, particularly adults, are discharged or never admitted in the first place, even when they're having severe pain. We acknowledge that, and many groups are working to fight against that. That said, during this pandemic, there has been a sense of urgency to get all patients, whether they have sickle cell disease or anything else, out of the hospital as soon as possible. We've been battling that in Connecticut for quite a while now. We were one of the first hardest hit states. We're right next door to New York. And so I can tell you, having been a physician on the inpatient hospital wards for 2 weeks in March when this was all exploding, people were not being admitted. And these are people who otherwise would have been admitted. These are people with bad diabetes, with bad high blood pressure. Emergency departments were trying to patch people up as best as they could and discharge them home, because the fear was that if they got admitted to manage their medical problem, they might catch COVID-19 in the hospital. And I also acknowledge that a lot of individuals with sickle cell disease who were admitted initially because of fever or because of severe pain A lot of hospital providers felt that they were doing something good by trying to get patients out as quickly as possible. So I think if you have felt a heightened push out of the hospital over the course of this pandemic, at least some of it may have been precipitated by some pressures that the hospitals were facing to primarily try to keep you healthy and from getting infected. You can imagine if you have a nurse or a doctor who's going from room to room to room before they see you, and they've picked up COVID-19 in the process and maybe don't even know it, and then give it to you, that's not anything that anybody wanted. So I think that I wouldn't be surprised if you recently noticed a heightened push to either not admit you or get you out quickly. But if you are faced with this, I would say to those people trying to discharge you, okay, what's the plan? Are you going to give me enough medication right now easily so that I can try to manage whatever I'm in here for at home as much as possible? Who is going to call me tomorrow to make sure I'm okay? Who do I call in the middle of the night tonight if I'm not feeling well? Is there a way for me to bypass the emergency department if I need to come back in? I don't know the answer to that. Usually it's not possible, but there may be a clinic that you're affiliated with who could see you and follow up and keep you from going back to the emergency department. So those are the questions to ask. And I think that, at least I hope that the people discharging you will realize that those are reasonable questions for which a reasonable answer and a plan of care needs to be developed.
Thank you, Dr. Andemariam. That was an excellent answer. I know we are at our time. I will, if you need to leave, that's certainly understandable. I will ask this one last question because I think it's very, very important. And that is, this is as a stakeholder community, what can we do to help those with sickle cell disease who are also disrupted by the rioting and the unrest? I think that's an excellent question because, just as COVID added another layer, so does everything that is happening around our country, and particularly here in Minnesota. We are uniquely challenged as being kind of the epicenter of where this is happening. We don't have any perfect answers right now, I realize that, but what can be done by those that truly do care, that are truly allies?
Speaking also, locally, I think that particularly, I think allies is their cells, but as Hailey said, our own cells, and particularly you as patients or those affected by it. Make sure you're taking care of yourself, making sure you're reaching out, seeing what people need. I know that Ray has been working, even yesterday, spending time working with family and friends to keep people safe. There's obviously, if you can help with food or a place to stay, those are important. Also, just be explicit and feel free to reach out to your providers. In some ways, we do just have a stronger voice to get things done. And so if you don't feel like you have another way to reach out and actually be hands-on with the community, which I think we all struggle with right now, to know how to do it, much less how to sort of understand it, much less do anything about it. Don't feel like you have to keep it in. Feel like if you just need a sounding board, or particularly if you think that the healthcare system can reach out in a way that we don't understand. I'm going to be the first to admit, I'm a white male who's a physician. I'm not there's lots of differences here, but it doesn't mean that I can't be your ally, and it means that I can actually have potentially a stronger voice to make things happen. Like I said, to not let the restrictions on opioids or transfusions from COVID limit our standard of care. But particularly when it comes to riots, we can also work and have a voice throughout our healthcare systems and say, these riots are, particularly for Children's and university, these are very close. Children's in particular, it was only a few blocks north of where the killing happened on Chicago Avenue, which is the same road. The precinct is just a little bit, is presumably even closer, kind of where the Hiawatha. So these are affecting there. Masonic Children's Hospital is less than a mile from the epicenter of the riots as well. So we are in the middle of it. We are, talking about it ad nauseum in terms of amongst physicians, but we need to know how it is affecting you, because it may be affecting me differently, or I may be thinking about it differently. But if I hear your voice and I can pass it on, and I can make sure that we're working as a system and working as a community, which is more than just the medical community, because sickle cell disease does not just affect you medically; it affects the whole life, and so find your resources, look to others, but we're all in this together, and I think we're all going to find it. We're going to figure it out together too. I don't think there's a blueprint that we can use, because all of this together feels really daunting.
Yeah, I agree. And just very quickly, one thing I will say on this is that I want to remind the sickle cell community, I know you don't need the reminder, that the sickle cell community has a long-standing history of advocacy that, by the nature of this, is deeply rooted in the African American. And it is possible that the sickle cell community, through the various member organizations, the national organizations, could work together during this civil unrest to be that voice. Individuals born with sickle cell disease I was muted for a second, but I think I hit the message home. So use your voice is all I wanted to say. You have more power behind your voice than you realize.
And I'll add in quickly too, Ray, just because this is, it's just such an important question and such an important topic. I just really want to echo the idea of checking in specifically with patients with sickle cell disease. I imagine that there's a lot of cognitive dissonance right now about wanting to be present at the protest, wanting to be present at the community cleanup, wanting to engage in that very present way, in that very physical way, and it's also not necessarily the safest way. So just recognizing that there's probably a lot of internal conflict among those individuals and their family members. And a conversation that we've had amongst my team here at Be the Match, and I know we were talking about it briefly as well before this webinar started, is showing vulnerability as providers and as allies, and taking the stance of being in a position to learn. I learned so much from my clients who are involved in the sickle cell disease community every single day. And I think it makes me a better provider, it makes me a better ally, it makes me a better community member. And so just recognizing that and truly taking that approach of following the direction of our community leaders and of those whose voices need to be heard and need to be uplifted in any way that they can. But I think that there's a lot to be said about that vulnerability piece. So just wanted to add that in as well.
Thank you so much. I think that all of those answers were incredibly gracious and very much meaningful, and hit the nail right on the head. I think that leaning in and sometimes just acknowledging that I see you. I would also encourage, see something, say something. When you see injustice, say something, particularly as we're talking about the sickle cell community and the interactions within the healthcare system. Even as a provider or a professional, it's important to utilize your voice in those areas. And then lastly, I will simply say that, if anyone knows me, I hate asking for donations, but I'm going to do it nonetheless. The Sickle Cell Foundation of Minnesota, we are currently housing 3 families who have been affected by the rioting. In addition, we have another, as Dr. Boucher said yesterday, I spent helping a number of families. So please continue to support us as we support the community. And volunteer where you can, and as the needs come up, to volunteer. If you're not sure, email us, send us an email. It's okay to ask, what can I do? Is there something that you need done? We pretty much always need something done. So Thank you so much. Again, our next Sickle Smart Summer session will occur on Saturday, June 27th at 10 a.m. You will be able to begin registering for that approximately 1 week prior. That's when we will make the link public. But we will make sure that you are aware of the topics at hand well in advance of that. We look to have the videos of the sessions uploaded to our Facebook page by the beginning of the week. www.SickleSellMN for Minnesota. That's SickleSellMN.org. And thank you once again to our speakers, our attendees, and our sponsor, our primary sponsor being the Links Incorporated. We are so appreciative for their support. Thank you very much, everyone. Have a healthy and safe day, and we look forward to seeing you next month. Bye-bye.